Well, welcome everybody to today's webinar. It's being presented by Ruiz Pozuelo, and Julia is a third-year DPhil student in our department, but she's also shared across our department and the Prevalence School of Government and the Center for the Studies of African Economies. Before joining us, she was actually an economist. She studied in Madrid and Berkeley, and also had a very and also a master in Oxford. But she also had a very important job, I think, for 3 or 4 years as a research analyst at the Global Economy and Development Program at the Brookings Institute in Washington, D.C., where she came across a whole range of well-known people. But we may have to ask Julia to come and give us another seminar about Michelle Obama and Joe Biden and other people she's once known, but that'll be for another day. But today, Julia is going to talk to us about work that she's been doing as part of her DPhil, which is depressive symptoms and risky behaviours amongst adolescents in low and middle income countries. And Julia, we look forward to hearing your talk. Thank you. Go ahead.
Thank you, Alan. And thanks everyone for having me and for being here. So as Alan mentioned, I'm a third-year DPhil student in psychiatry. And the overarching topic of my DPhil is looking at the relationship between depressive symptoms and risky behaviors among adolescents in low and middle income countries. So I want to start off by giving a bit of background on the topic and why I think it's an important topic to focus on. So adolescence is a period of opportunities. There are many changes that happen during this time. There's biological changes, cognitive and social changes. It is also a time where adolescents start to develop their own self-identity, and they start to make key decisions about schooling, entrance into the labor market, sexual relationships. So while it is a period of opportunities, it is also a time of vulnerabilities. Risky behaviors such as substance use and unsafe sex start to emerge during this time. And also the incidence of depression peaks. The bar chart on the right shows the prevalence of major depressive episodes by age. And I did this using data from the US. And as you can see, in the very left bar refers to 12-year-olds. And you see that almost 5% suffered a major depressive episode at that age. And then from then on, there's a very big increase in the prevalence of depression, peaking at age 17 with 18.5%. And then the prevalence for older age groups is lower from then on. In addition to this, adolescents in low and middle income countries face major disadvantages. The pie chart on the left shows that about 2/3 of all the people living in extreme poverty in the world are actually younger than 25 years old. And I did this using data from the World Bank, which defines extreme poverty as living below $1.90 a day, so a very low threshold. The bar chart on the very right shows the annual government mental health expenditure by country income groups, also defined by the World Bank. So you see that the low income countries are on the very left, and it goes all the way to high income countries on the very right. So in general, you see that spending levels across every single low and middle income countries are very low, but these are particularly low for low income countries that spend 2 cents per person per year on mental health. So adolescents are not only struggling because of poverty and the consequences of poverty, but there are also much less resources for those that are in need. So 3 years ago, I started working on a trial with Alan Stein and a very multidisciplinary team on a trial that is based in rural Northeast South Africa. You can see it on the map there called Agincourt Study Site. So the site has around 31 villages and has around 150,000 people, many of them adolescents. And the primary objective of this trial is to test an intervention that is aimed at treating depression among adolescents living in this rural area. The photo on the right is one of the photos that I took in one of my trips. And so through my work and my travels here, I started to familiarize myself with the site and just more generally with the struggles that adolescents in rural areas face. And among one of the biggest struggles perhaps is HIV. It really stands out. South Africa has one of the biggest HIV epidemics in the world, with almost 8 million people living with HIV. And this graph shows the HIV prevalence in Agincourt by age and sex. So as you can see, HIV prevalence really increases significantly during adolescence. So women aged 15 to 19 start at around 6% prevalence. And this prevalence increases steadily, reaching 42% by the time they reach 30 to 34 years old. And this trajectory is slightly different for males, but they still reach very high prevalence rates by the same age, 30 to 34 years old. So I decided to explore a bit more, and I started to work with data that was collected actually in Agincourt. This table shows data from a trial with adolescent women aged 13 to 20 at baseline. And so the very left column, you see the non-depressed sample. And then in the right column, you see depressed adolescents as defined by the Children's Depression Inventory Scale. So as you can see the difference, so those that are depressed are more likely to ever be pregnant, more likely to have had sex before the age of 15, to have unsafe sex, to engage in transactional sex, which is defined as sex in exchange of money or gifts, to have had sex with an older partner, and to have multiple partners in a year. Adolescents with depression are also more likely to repeat a grade in school and to perform worse than non-depressed adolescents. They're also more likely to drink alcohol and to ever take drugs. And all of these differences are highly significant. So that brings me to my DPhil and my PhD. Let me just briefly give you an overview of the chapters, and then I'll delve into one of them. So in chapter 1 of my thesis, I used data from a cohort study of adolescents in Agincourt to study the risk and protective factors for depression. So in terms of risk factors, I mainly focus on structural factors such as socioeconomic status and the education level of the parents or the caregivers. I also look at stress factors such as being exposed to violence or food insecurity or losing a parent. And then in terms of protective factors, I look at the role of parental involvement, friendships, and community support, so more on the social capital front. In chapter 2 of my thesis, I conduct a systematic review and meta-analysis to look at the effect of depressive symptoms on risky behaviors. In chapter 3, I look at the bidirectional relationship between depression and risk-taking, also using cohort study from Agincourt. And then one factor that may moderate the relationship between depressive symptoms and risk-taking is executive function, which is a family of mental processes that really help us to concentrate, to pay attention, to plan for the future, to adapt to new situations. And evidence from high-income countries shows that depression is associated with impairments in executive function, and that in turn, deficits in executive function predict risky behaviors. However, this relationship, actually, to our knowledge, has not been explored in low and middle-income countries. So in chapter 4 of my thesis, I look at this association using data that I'll collect in rural Uganda. And so in this seminar, I will present the results from chapter 2 of my thesis, so the systematic review and the meta-analysis. So this is joint work with Lucy Desbrough, who's an assistant psychologist at NHS Foundation Trust, with Professor Andrea Cipriani, who's based at the Department of Psychiatry in Oxford, and with Professor Alan Stein, who's a professor of child and adolescent psychiatry. And I was struggling to find a photo of Alan, and he recently shared that with our team, and I thought it was too good to miss. So the main research question of this study is whether depressed adolescents are more likely to engage in risky behaviors compared to non-depressed adolescents. And so overall, we do know that depression affects the way we perceive risks, but really the direction of effects is not really clearly understood. So on the one hand, you could think that someone that is very severely depressed with very high levels of avoidance probably stays more at home, so probably takes less decisions and overall takes less risks. On the other hand, we know that depression results in low levels of self-esteem, feelings of hopelessness, and so this might make an individual more prone to engage in risky behaviors as a coping mechanism or as a way to seek relief from the symptoms. So evidence from high-income countries show that adolescents with depressive symptoms are more likely to engage in risky sexual behaviors, such as engaging in unsafe sex, having multiple partners, or being pregnant. It's Similarly, studies looking at this relationship with substance use also see that depressive symptoms predict higher consumption of alcohol and drugs, and is also associated with subsequent onset of substance use disorders. But most of these studies have explored this association in high-income countries. And to date, there's actually no systematic review that looks at this association in low- and middle-income countries. And this is surprising because 90% of the world's adolescents live in low- and middle-income countries. So given this gap in the literature, our objective was to identify and systematically review all of the relevant literature, reporting on the association between depressive symptoms and risky behaviors among adolescents living in low- and middle-income countries, and to provide a quantitative summary estimate of the extent to which these two are associated. So I'll briefly go over our methods section now. So in developing the structure of the review, we adopted the PICO approach, which defines the relevant population, exposure, and the comparator and the outcome. And so we also follow the PRISMA guidelines to conduct this review, and we register the protocol in Prospero before conducting the searches. And so as you can see, our population was adolescents aged 10 to 24, living in low- and middle-income countries at the time of recruitment. The exposure is depressive symptoms, and we compared this against non-depressed adolescents. And our outcome is risky behaviors, which I'll define in 2 slides. In total, we searched 15 different databases for both published and non-published databases. We also included longitudinal cohort data of adolescents living in low- and middle-income countries, such as some studies that were conducted in South Africa, in Brazil, in the Philippines. And then we also hand search reference list of eligible articles to supplement the database searches. Our core search consisted of terms related to depressive symptoms, risky behaviors, adolescents, and the specific study setting. So all of the different low- and middle-income countries as defined by the World Bank. And then the search was conducted in late April last year, and we applied no restrictions on date, language, or publication status. So our inclusion criteria matches many of the things that I already mentioned in the PICO approach, but in addition to those, we also included studies that were cohort and case control studies in their design. Studies had to measure depression using either the diagnostic interviews or validated screening tools of depression. Studies had to measure risky behaviors using biological markers, administrative data, or self-reported measures. And then importantly, the studies also had to control for the outcome at baseline. So they had to control for the specific risky behavior at baseline. So in this review, we mainly focused on risky health behaviors. And specifically, we focused on 2 primary outcomes. We define risky sexual behaviors as any behavior, sexual behavior that increases an individual risk for sexually transmitted infections or an STI or an unwanted pregnancy. So this includes being diagnosed with an STI, having unprotected sex, and an intended or teenage pregnancy, multiple older partners, or engaging in transactional sex. Similarly, we define substance use as any use of alcohol or other recreational drug. So studies had to include measures of alcohol and tobacco consumption, drug use, or any other substance use dependence symptoms. These are our secondary outcomes. So we included studies that measured delinquency, risky behavior in school, self-harm, and suicidal behavior. And the studies had to measure this either using official policy records in the case of delinquency, or self-reported measures, or even administrative school data in the case of risky behavior in school. And we included studies that reported odds ratio adjusted for at the very minimum age and sex. We pulled all of the studies using the random effect model. We used the Newcastle-Ottawa scale to assess the quality of the studies, which is basically a scale that assesses the quality in 3 very broad dimensions. So first, how are the different study groups selected? So how are the depressed and the non-depressed selected? How comparable are these 2 groups? And then how is the exposure and the outcome measured? So how is depression and how is risky behaviors measured? And then we measured the between study heterogeneity using I-squared and explored some of this heterogeneity using subgroup analysis. So overall, we got a total of 31,148 potential studies. Luckily, 4,500 were duplicates, but that still left us with over 26,500 articles to review. And following the guidelines, Lucy and me independently screened all of the different potential studies. So as you can imagine, we got quite a bit of practice at socially isolating already at the time. In the very first screening phase, we read over 26,500 title and abstracts and excluded 90% of the studies. In the second phase, after reading 701 articles, we excluded 668 and recorded a reason for exclusion. And then we also contacted authors of all of the including studies whenever key information was missing. So after a lot of reading, we included 33 articles in the study, of which 30 comprised the meta-analysis. So there were 3 which did not report the adjusted odds ratio, or we could not pull them together. So this table shows you the number of studies per study outcome. So we had 7 studies that measured the association between depressive symptoms and risky sexual behaviors, 10 that measured it with substance use, and so forth for our secondary outcomes. Something that I think is actually interesting is that we did not find any study reporting on the association between depressive symptoms and risky behavior in school. In terms of study design, we had a bit more than a third being cohort studies and 2/3 case controls. And then most of the studies were peer-reviewed journals. We included 1 abstract, and then we included 3 cohort databases with data from adolescents living in the Philippines, in Brazil, and in South Africa. And so we conducted actually the analysis for Philippines and South Africa, and because the data was open access. But in the case of Brazil, we asked the PI of the study or someone in the team to actually conduct the analysis for us. 2/3 had high quality, according to the NOS scale, the Newcastle-Ottawa scale, 2 moderate and 1 low. And that was the abstract. We had very little information to assess against all the 3 dimensions that I mentioned before. So pulling all of the data together, we got a total of almost 36,000 adolescents living in 17 different low middle income countries. So it was 5 from Africa, 7 from Asia, and 5 from Latin America and the Caribbean. So now on to the results. So this first plot summarizes all of the studies that we found reporting on the association between depressive symptoms and risky sexual behaviors. Let me briefly explain how to read this first plot for those that are not very familiar with it. So the column on the very left shows all of the included studies. And so the studies are represented by the name of the first author and the year of publication. The next column shows the study results, or the odds ratio. And this is also represented on the graph with a gray box. So the horizontal lines through the boxes show the length of the confidence interval. So the longer the lines, the wider the confidence interval. And so the less reliable the study results are. The last row that's in green, and the green diamond at the very bottom shows the pooled odds ratio. And again, similar to above, so the width of the diamond also shows the confidence interval. So the wider the diamond also implies a wider confidence interval. And the key thing to look at here is whether the odds ratio is significantly different from 1, which is the vertical line there in red. So just to say, so an odds ratio higher than 1 means that depressive symptoms are associated with more risky behaviors. An odds ratio lower than 1 means that depressive symptoms, of course, is associated with less risky behaviors. And the vertical line at 1 is the line of no association. So if the diamond, the green diamond touches on that line of no effect, it means that there's really no difference between 2 groups, the depressed and the non-depressed. The last column, the weight, indicates the influence that each individual study has had on the pooled result. So in general, the bigger the sample size and the narrower the confidence interval, the higher the percentage weight. And this is also actually represented by the size of the gray box. So with the bigger the gray box shows the study has had a bigger influence on the pooled results. Okay, so hopefully that's a bit more clear now. So what did we find? The pooled odds ratio for the 7 studies that reported on an association between depressive symptoms and risky sexual behavior shows that shows that the adolescents with depressive symptoms are actually more likely to engage in risky sexual behaviors compared to non-depressed. Put differently, there's almost a 30% increase in the odds of engaging in risky sexual behavior given depression. So this first plot shows the same results for substance use, so our other primary outcome. So the pooled odds ratio for the 10 studies show that adolescents with depressive symptoms are more likely to engage in substance use compared to non-depressed adolescents. Similarly, so there's an 80% increase in the odds of engaging in risky in substance use given depression. And in both first plots, you can see there's a very high heterogeneity of around 74 to 77%. So this is something that we actually explored in subgroup analysis later on. And these are the results for the secondary outcomes. And in general, they show very similar patterns. So we find higher delinquency, higher self-harm, and higher suicidal behavior among depressed adolescents compared to non-depressed. And here, actually, we see much lower heterogeneity, and especially for self-harm and suicidal behaviors. And one reason for this is actually most of the studies just use the exact same measure to measure these outcomes, so the same scale. So are depressed women more likely to engage in risky sexual behavior compared to depressed men? So this first plot answers that question. So while we find actually an association between depressive symptoms and risky sexual behaviors among women, we don't see an association for men. You can see actually that the green diamond touches the vertical line at 1. So, and this difference between females and males is statistically significant. So the p-value you see it below is 0.001. So the women have higher odds ratio for compared to males. And we do the same exercise for substance use. So are depressed women more likely to engage in substance use compared to depressed men? And actually here, when comparing both groups, we see no statistically significant difference between them. So you see again, the p-value, the very low row, is 0.442. And so we conducted some other subgroup analysis. So depending on the study design, whether it was case control or cohort, how depression was measured, diagnostic interviews or validated screening tools, or how risky behaviors were measured. But I won't have time to go over them now. So in summary, we find that adolescents in low and middle income countries with depressive symptoms are more likely to engage in risky behaviors compared to non-depressed adolescents. And these findings are consistent with the evidence from high income countries that I mentioned at the very beginning of the presentation. And there are several mechanisms that could explain these results. One view, which is often referred to as the self-medication hypothesis, suggests that depressed adolescents might engage in risky behaviors as a way to seek relief from their symptoms or even to experience emotions. So for example, someone might engage in drinking alcohol or in risky sex as a coping mechanism to regulate negative emotions. Second, depression is also known, as I mentioned before, to affect cognitive functions, such as our ability to resist temptations or how we value rewards, so our reward processing. And so this may result in higher risky behavior engagement. And lastly, we know that depression is also associated with negative cognitive biases, such as low self-esteem, avoidance, rumination, hopelessness. So this might actually make a depressed individual more prone to engage in risky behaviors. And of course, none of these mechanisms are mutually exclusive, right? So the mechanism may in fact be a combination of all of these three. And so we cannot test, unfortunately, any of these possible mechanisms with the type of analysis that we conducted, but I think it will be very important as an area to moving forward for other studies. We will be able to test actually the cognitive function mechanism in the trial that I'm part of in rural South Africa. So to end, let me just talk a little bit about the implications of this study. So first, in this meta-analysis, we show that depressed adolescents in low and middle income countries carry a double burden. So they not only suffer from depression, but in addition, they are at an increased risk of engaging and really suffering the negative consequences of risky behaviors. And so this combination may result in further psychological and physical health problems that persist over the life course. And this may impose a significant health burden on the individual, on their families, and really on society as a whole. On the depression side, we also know that risk factors for depression, such as poverty, violence, forced migration, are also more prevalent in low and middle income countries. So this actually really suggests that the total number of depressed adolescents is substantially higher in low and middle income countries compared to high income countries. So together with the results from this study, this means that there's a higher share of adolescents that are more likely to engage in risky behaviors. On the risky behavior side, so some countries, mostly from high income countries, also have programs in place, such as rehab programs or peer support programs that really help adolescents to get back on track if they need the help. But this type of support is virtually non-existent in low and middle income countries, which make adolescents even more vulnerable to the negative consequences of risky behaviors. And lastly, our results also highlight the crucial role that effective preventative interventions can play to identify adolescents at an elevated risk of depression and risky behaviors. And just the need for low cost and scalable treatments for depression among adolescents in low resource areas. So just a big thank you to my supervisors, Alan Stein and Stefan Derkon, and to my funders. And yeah, and that's my email and contact details in case anyone has any question.